We're going to go over the shoulder assessment today. So, how do we do a shoulder evaluation? I have a handout for you in the class, so please have that. Look at that while you're following along with me. History, you'll see through most of these lab injury evaluations, we follow the same kind of steps as any other body part. We're just trying to figure out what happened here, so we have to develop some good questions to ask the patient or the athlete how the injury happened, what did they experience when it happened, what's their pain like, any previous injuries to that body part, anything you can do to gather information about the injury to help you understand what happened, what's their signs and symptoms, or actually their symptoms, because the signs is what you touch and feel that they are experiencing. So we'll move on to inspection. So we look on the front side, the anterior inspection. Are both shoulder tips even? For a man, they'll probably take their shirt off. For a lady, we'll have them in a sports bra so we can see their shoulder. Are the shoulder tips even? Is the lateral end of the clavicle prominent, or is it flat? Is there a loss of normal curvature to the deltoid? Is there an indentation at the upper biceps region? Is the athlete favoring one side or carrying their arm? These are just some examples of the things we're looking for when we look straight on. Then our lateral inspection. Are there any excessive kyphotic curve? Squared middle deltoid, that's their shoulder, side of their shoulder. And then the posterior inspection, we want to see if the scapula are the same, or is the scapula winging? Do they have a lower shoulder than the other side? Is the spine straight, or is there a lateral curvature to that? So again, we're just looking for clues to what's going on in the shoulder. The shoulder is a very difficult aspect of our body to determine what injury a person has. It takes a lot of practice. I have provided a video on how to do the palpation, so you can see how to do that. Range of motion test, and here's a quick and dirty test. It's called Apley Scratch test for active range of motion. The test abduction and external rotation. You have them reach behind the head and touch the opposite scapula, like shown in the picture. Then to check adduction and internal rotation, we have them reach the opposite shoulder or reach behind the back and touch the opposite shoulder. All right. Here's our range of motion and the degrees of motion for each this, for abduction and adduction, flexion, extension, internal and external rotation. Our stress test for the shoulder, we're going to start with the AC joint. I talked about it in a lecture, the spring or piano key test. Press down on the distal clavicle. A positive sign is the clavicle depresses like a piano key, and they have pain. And now we have some special tests. The first one is the drop arm test. This is for the supraspinatus in the rotator cuff. We passively abduct the shoulder to 90 degrees and ask them to slowly lower their arm, or you can tap their arm. I've seen it, I do it both ways just to see, compare the two. So again, you bring it up to 90 degrees on their side, then slowly ask them to lower the arm down or tap their arm down. A positive test is the arm drops, or we have an uncontrolled movement. They can't stop their arm from moving down because if the supraspinatus is torn, they can't stop that motion. It just drops on them. The Centinella or the empty can test, like you think about it, we have an empty can in our hand. Another supraspinatus test. We abduct the shoulder to 90 degrees with internal rotation and elbow flex at 90 degrees, and you pretend you're pouring a can. That's the motion that you want the patient to be in. Those arms, the arms are down, so they're pouring a can. We push the arms down. We ask them to keep me from pushing your arms down, and the positive sign is weakness or arm drops, and there's pain with this. So these are all for the supraspinatus, potato. Speeds test is for the biceps tendonitis or bicipital tendonitis. We have the elbow extended. We palpate the bicipital groove where in the picture there you can see the athletic trainer's thumb is at. We ask them to do shoulder flexion with supination and pronation. That's the turning. We haven't done elbow yet, but that's in the elbow, the pronation and supination. So we ask them to resist shoulder flexion, and then you have them flex, supinate and pronate their forearm. So the positive sign is weakness and pain, really pain over that bicipital groove is where they experience that pain, because that's where that long head of the bicep tendon travels through. Another test for bicipital tendonitis. We have the elbow flexed, it's called Yergason, forgot to say the name of the test, Yergason's test. Elbows flexed at 90 degrees, as you see in the picture next to the person's body. Resist supination while also externally rotating the arm. We have a positive test when the tendon pops out of place, or we have it increases tenderness and pain at the bicipital tendonitis, the bicep tendon. Neurological, see the lab handouts, really just more for your information than anything. That's what we'd do next. Circulation, we would always, when I talk about checking a distal pulse in the lecture, the brachial artery is on the medial side of your upper arm, right out the elbow, right where you bend your elbow. Your radial artery is at your wrist, where you typically would take your pulse. And when we talked about checking pulse and all that stuff, we talked about it at the radial artery. Again, we do check distal pulse to make sure the person has blood flow down to their fingers anytime we have a severe upper body injury. Functional tests, sport or activity specific activities such as throwing, shooting basketballs, running motions when they run. Can they move their arms normally? Anything else you can think of? Just check their functionality of their upper body or their shoulder. Review. Remember in the book they talk about the HIT steps. The history is H, and that's the history and the process that I follow. I is inspection. That's for me, that's bilateral visual observation. T for the HIT steps is touch, which is palpation. And my process, what the HIT steps don't have are these things: the range of motion and muscle testing, stress and special test, neurological, circulation, or functional test. Just keep that in front of your mind here.